Last week, we went over most of the oral medications that we'll use for type 2 diabetes, and now we'll go into the injectable medications. Some of these are just used for type 2, some are just used for type 1, and then some are going to be used for both, depending on the patient. So we have both non-insulin and insulin injectable drugs. First, under our non-insulin injectables, we've got our GLP-1 receptor agonists, our glucagon-like peptide-1 receptor agonists, like semaglutide, exenatide, liraglutide, dulaglutide. Most of these are ending in that tide suffix, which these are going to help enhance our glucose control. And then we also have our amylin mimetics, like our pramlintide. So don't get those tides confused since they both end in tide there. And those are going to work by slowing gastric emptying to help with our glucose control. Then we've got our insulin therapy. All of our insulins will mainly be talking about our injectables. We'll quickly go over one or two that are not. Our options are going to range from our rapid-acting insulin like Lispro, short-acting regular insulin, intermediate like our protamine insulin, and then long-duration insulins like Glargine, Degludec to give us a bit more extended glucose control. Getting into our injectable medications, our non-insulin ones, we're going to start with our GLP-1 receptor agonists, which are going to mimic the effects of the natural incretin hormone, which is usually released by the stomach, the gut after meals to help regulate glucose metabolism. It does this by slowing gastric emptying. And if you delay gastric emptying, these are going to help slow down how food exits the stomach, which is going to help reduce our postprandial blood sugar spikes. So typically when you eat, after you eat, you get a spike in blood sugar. This is going to slow down that process to make it more of a steady raise in blood sugar and not a big spike. It's also going to increase our insulin secretion. And it's going to do this through the pancreatic beta cells, but it's only going to do this when our blood glucose levels are elevated, which is going to help not cause hypoglycemia in like a fasting state or someone that doesn't have high enough blood sugar to need their sugars to go down. We also are going to decrease our glucagon secretion. And glucagon is typically a hormone that increases glucose production by the liver. So if we're decreasing that, it's going to help keep our blood sugar levels lower. And then it's also going to help suppress appetite. So if you're not eating as much, you have lower calorie intake, it's going to help with weight management, it's going to help with sugar management, and that's going to be a great effect overall for our diabetic patients. But as with any medication, we do have to worry about our side effects. So most common, you're going to get so many people complaining of these, of nausea, vomiting, diarrhea. So our GI side effects, especially in the early treatment phase as your body's trying to adjust to these medications. This tends to be the worst thing that people complain about because it's also the most common. You can get some with any injectable and injection site irritation. There is a risk of inflammation of the pancreas, pancreatitis, so you do want to monitor for any severe abdominal pain. There can be some renal impairment, so you don't want to use these with someone that already has kidney disease, which is already a concern with our diabetic patients. These are teratogenic, so don't use them in our pregnant patients, or make sure that you are counseling on someone that has the ability to become pregnant. Hypersensitivity reactions like our anaphylaxis, Stevens-Johnson, although those are fairly rare. And then you see some mixed information about thyroid carcinomas. There has been some studies showing a slight increase in developing a medullary thyroid carcinoma. particularly in those that are already at risk of that. So someone that has like MENS 2, which is multiple endocrine neoplasia type 2. So these are going to be contraindicated in those patients that already have a risk of that. GLP-1s are a great medication, not only for diabetics, but we're seeing them used for weight loss as well. Um, but there is some cons to it. There are some reasons why it's not something we can just give to everyone, unfortunately. Um, they're great at aiding in weight loss and managing our diabetic sugar control, but cost tends to be a significant barrier. They're often super expensive, and not all insurance plans will cover them because there are other cheaper options out there. So it can lead to pretty high out of pocket costs for our patients. Administration can be a challenge because they're an injectable compared to an oral type medication, which can also lead to commitment or compliance adherence issues with our patients. And then, like I said previously on our other slide, nausea and vomiting tend to be a very common side effect. So that can be a big con of the GLP-1s also. There are some ways we can try and reduce the costs, though, to try and help with one of those cons, and that is through copay cards from our manufacturers. A lot of times they have copay cards that they can get at least a few months' supplies for fairly cheap. It does typically depend on what kind of insurance they have. With these medications being utilized much more often now too for weight loss, we're noticing shortages of them for our diabetic patients. So that's something that you have to keep in mind also when you're talking about starting someone on these right now until production kind of ramps up. And then there's also some patient assistant programs. They can either look online or try and talk with the pharmacist. Certain local areas have certain medications on some sort of assistance programs to get these fantastic medications to the patients that need it. Not many of our patients are going to be used to how to use these types of medications. So you do have to make sure that you give them proper education about how to not only use them, but store them. And that's going to be crucial to your patient education once you do prescribe these. Unopened pens should be kept in the refrigerator, but once they are open, most pens can be stored at room temperature for about 30 days. So cool, dry place, 30 days. Um, there is a little bit of leniency depending on which type of medication. So if you have like Ozempic, that brand name, that can last up to 56 days or so, while Trulicity is only good for about 14 days. So it does depend on the brand. So you do need to make sure that you're looking up this information for your patients until you get it kind of in your head. When you are going to instruct them how to use it, you typically need to prime the pen before you use it. So they'll have instructions on how you prime that pen, meaning you gotta get it to the point where you have the amount ready to go and inject, and not just you're not injecting air or anything like that. For Bidurian, which is a different kind of brand, you do have to mix the injection before as well. And typically, you're going to want to make sure you tell your patients to eat within an hour um, after an injection. If they can't eat within an hour, don't inject because you don't want them to get those big side effects that we talked about. Injecting closer to a meal can also help with nausea and help promote a feeling of fullness so they don't eat as much. And if they're going to miss a weekly dose, just make sure that they remember as soon as possible, but that it's no more than, or it's got to be more than 3 days since their last dose. You don't want to double up on the doses at all. We talked about how you have to train or teach your patient how to properly administer medications when we talked about like our inhalers, our nebulizers with asthma. Same goes for our diabetics with their pens and their insulins. So you're going to see a cap and the window, you're going to remove the cap, and that's where their needle is. The window is going to show if the pen is ready for use. It should be clear, have no air bubbles in the medicine, and that's going to be part of what they need to do to start before they start priming the pen. They're going to turn that little dose selector to the appropriate dose until they see a drop of medication at the needle tip, and that ensures that there's no air bubbles, anything like that, and the pen's ready for injection. Always hold their pen upright to ensure proper delivery of the medication. They'll set that dose on the dose selector. You'll hear clicks for each unit that they select. And then certain medications, they're going to have to shake it before they take it type thing. Sometimes 80 times or more to make sure that the medication within it is properly mixed and they're going to get the proper dosage of the medication. When they do go to inject it, they're going to need to press that injection button firmly down for 6 seconds after the injection to make sure that the full dose has been delivered, and then they can remove the pen from the skin and then just make sure again they put the cap back on. And then most of these, like I said, can be stored for a certain amount of time and room temperature, depending on what medication it is how long, whether it's 14 days, 60 days, it depends on what the medication is. I threw this slide in here really quick just because there is an oral version of the GLP-1 agonists, the semaglutide oral version. You don't see it used as often, and that's just because even though it is effective, the injectable form has demonstrated much superior efficacy in reducing patients' hemoglobin A1C levels as well as with weight loss compared to this oral version. So I'm just letting you know that it exists in an oral version, it's just not as effective. Briefly touched on tirzepatide when we talked about weight loss medications last quarter. And this medication is a combo one. It's got our GLP-1 receptor agonist, but it also works on the glucose dependent insulinotropic polypeptide, or the GIP receptors. And with that combination, we're noticing a huge amount of weight loss. It's very high weight loss. It's highly effective in A1C reduction. So this just got approved within the last year as a weight loss medication in and of itself, but it's also a great option for our diabetics. But again, cost can be somewhat prohibitive for our patients. We've touched on both of these classes, your SGLT2Is, your sodium glucose 2 transporter inhibitors, and your GLP-1 receptor agonists, and how they can be beneficial for atherosclerotic cardiovascular disease, your ASCVD, heart failure, renal protection, um, your SGLT2 inhibitors, your flozins, are great for all of these. They will be helpful with reducing heart failure hospitalizations. They've demonstrated reduction in cardiovascular events. They've also shown protective effects for reducing our albuminuria and slowing progression of our kidney disease. And then our GLP-1s have been shown also to reduce cardiovascular events as well as be renal protective. They don't have as much help in treating or reducing heart failure hospitalizations, but you do want to keep these in mind if you have a diabetic patient, even though like a metformin, something like that is typically first line, these might become your first line for those patients with these comorbid conditions. And our last non-insulin injectable that we're going to talk about is our amylin mimetic, our pramlintide. So amylin, pramlin, that's how I kind of try and put those class and meds together. It is indicated, interestingly, compared to other ones for both type 1 and type 2 diabetes, and it's the only non-insulin agent approved for type 1 diabetes management. How it works is it's going to mimic those effects of amylin, which is a hormone produced by the pancreas. And doing so, it's going to help complement those effects of insulin by reducing those postprandial glucose levels, keeping that spike from happening, also decreasing the glucagon production, which is going to decrease our glucose levels, slowing gastric emptying. Again, that's going to slow or decrease our spike of postprandial glucose levels, and increase that feeling of satiety, making them feel full faster. So works very similar, just through a different hormone than our other injectables that we've just talked about. You do, with any medication, have some common side effects. Like with a lot of these, there's going to be nausea, vomiting, some abdominal pain, decreased appetite. This one does, though, have a severe hypoglycemic risk, particularly if you are administering it within 3 hours of an insulin. So you want to be careful having these as a combo with insulin as well, because you don't want to send your diabetic into like a hypoglycemic issue, a hypoglycemic shock. So that is our one non-insulin injectable that can be used for our type 1s as well. And then it can also be used in our type 2s. On to our insulin injectables. So these are going to be your cornerstone of treatment for your type 1 diabetics. And it's can also be used in your type 2 diabetics, especially as their uh, own insulin stores start to deplete or insulin sensitivity starts to decrease. Our insulins are going to be categorized really in two main types. We've got our bolus insulin, which is going to be our prandial or mealtime insulins. These are typically more rapid acting or short acting medications that are going to be administered just before or shortly after meals to manage those postprandial glucose spikes. And then you've got your basal insulins, which are going to be our longer acting, our intermediate and our longer acting medications. You've got your NPH insulin, which is more an intermediate, maybe lasts 10 to 16 hours, gives a little bit of blood sugar coverage throughout the day, versus our insulin glargine, which is up to 24 hours, and insulin deglutic, which can be up to 42 hours. This allows a little bit more flexibility in dosing, less injections, and long-acting glycemic control. A lot of what we're going to use, we'll go over in the next few slides here. It's really going to be tailored to meet individual patient needs. So what does your patient need will help us decide what types of these, what combo of these are we going to use. Again, insulin, our backbone of really our type 1 diabetics, and then can also be used in our type 2, as well as our gestational diabetics. For our uses, our type 1s, it's going to be essential for all of their patients because these type 1 diabetics don't produce their own insulin. In our type 2 diabetics, it's going to be used like when our oral medications aren't sufficient. they're not managing our glycemic control as well as we need to, or if they're in a time of stress or illness and they need extra control. And then for our gestational diabetics, they're going to be used when diet and exercise alone aren't controlling blood glucose levels during pregnancy. Insulin, just like the natural hormone, is going to lower our hepatic glucose output, decrease the amount of glucose that the liver is putting out. It's going to increase glycogen synthesis, which is going to help promote storage of glucose as glycogen in the liver and the muscles. So that'll decrease those glucose levels as well. It's going to, again, pull that glucose into the muscle cells for energy and storage. It's going to naturally, it'll secrete in response to glucose by the pancreatic beta cells. Obviously, this doesn't happen in like our type 1 diabetics or further progressed type 2s. And we're using it to try and help maintain a euglycemia. So they're not hypo, they're not hyper. We're keeping them in a normal range. But as you can imagine, major side effect of insulin is hypoglycemia, because that's its purpose, is to decrease glucose levels. So if you're using too much of it and you're not adjusted according to like your dietary intake or how much activity you're doing, hypoglycemia is a huge risk. And then insulin therapy can also cause weight gain. And a lot of times this is due to increased calorie intake and changes in our metabolism. I briefly touched on this on just the different categories of our insulin, but there's going to be two key components of glucose control and what we're trying to control and what we're trying to do with insulin. And that's going to be controlling our fasting plasma glucose and our postprandial plasma glucose. Our fasting plasma glucose is typically going to be controlled by our basal insulins. So these are our intermediate or long-acting insulins, like our NPH or degludec, those type of insulins. And this purpose is going to be to suppress glucose production between our meals as well as overnight to try and maintain a constant blood glucose level, to not have our fluctuations. Our dosage for this is going to be about half or 50% of our daily insulin requirement. Our fasting plasma glucose management is often going to require a combo of both basal and bolus to kind of achieve that steady glucose level, but our main guy for it is our basals. And then we're wanting to control our postprandial plasma glucose. These are going to be our bolus or our prandial insulin. So like our short-acting regular insulin or our rapid-acting Lispro. Purpose of this one is going to be to limit that spike, that hyperglycemia that we get after meals by giving kind of that immediate rise in insulin to match that increase in carbohydrates that we're getting from eating our meal intake. So typically when you eat, the body converts those carbohydrates into sugar. And so to try and again keep that at a steady level, we give what naturally happens in the body, a little spike of insulin to keep it at a steady level. And then our dosage for this is going to be about half of our daily insulin requirement as well. But instead of in like a one-time dosing or two-time dosing with our basal insulins, we're going to divide that need between the meals for each day. And we'll go over a lot of how to do that, or what I'm talking about with that, in the next few slides here. But typically, again, you are going to need a combo of both a basal and a bolus to get optimal control for your patient and reduce those risks of complications. This guy is just an FYI. There is a inhaled version of insulin. It's not used as often. And then it's going to be obviously contraindicated in our patients that have any acute bronchospasm risks like asthma and COPD. But again, just FYI. Starting with our short duration rapid acting insulins. These include our Lispro, our Aspart, and our glulisine. These are the fastest acting insulins and are going to provide really quick onset of action to manage those blood glucose levels effectively. They're typically peaking within about an hour after meals. So they're going to be doing that work to decrease those postprandial glucose rises really quickly. So you're going to use them with your meals. It's primarily used again to decrease or control that postprandial glucose spike that you get right after eating. Most of these can be administered either sub-Q or through intravenously IV. You're going to want to administer these though about 15 minutes before a meal in order to optimize those insulin levels and get the body prepared for that meal, that carbohydrate intake. Postprandial, you can give these within 30 minutes of starting a meal if the pre-meal dose was missed, or if for some reason you need some sort of correction dose or immediate action needed. We're going to go over a bit as far as what correction doses mean, but correction doses with these are going to be useful for managing that hyperglycemia that occurs in between meals. And then these can be used for like more flexible dosing based on if you take your blood sugar and whatever you had given yourself before wasn't enough, that you still have some hyperglycemia postprandially. So, I love my little mnemonics or ways to remember things. So here's what I've got for our rapid acting. We've got our Lispro. It's a pro, so it does things in less time. So insulin Lispro works quickly. It's a pro, it does it in less time. Glulisine goes like a limousine. It's fast, so limousines are fast. So glulisine is fast like a limousine. Lispro is a pro, it does it in less time. And then I won't say this one completely, but insulin aspart, it gets your bottom parts moving, so it's rapid acting. And then we have our other short duration regular insulin. It is a short acting insulin. When I say that it is slower acting, I just mean in comparison to our rapid acting ones, our Lispro, glulisine, those ones. So it's not slow acting, it's just slower than the rapid. It's still a short acting medication that's used for more of a gradual onset of action compared to those rapid acting insulins, because its peak is going to be about 2 to 4 hours, where those rapid acting ones, it was about 30 to 60 minutes. So we can use these sub-Q. They can be used for our pumps. Our regular insulin is infused sub-Q through our insulin pumps. And then it's also ready to go in the IV. This is so regular is ready to go in the IV. Again, our peak is about 2 to 4 hours after administration. Uh, and this is just going to be a slower acting option for our diabetics. It is still what we will use or an option to use for our postprandial control because it is a short acting medication. Onto our intermediate duration, which is going to be used for our basal or longer term control. And our intermediate duration insulin that we're going to use is our neutral protamine hagedorn insulin suspension, otherwise known as NPH insulin. So NPH is an intermediate duration insulin. A key feature to let you, if you have two insulins in front of you and you know it's NPH, is because NPH typically has this cloudy appearance to it because it has the protamine in it. And the protamine is in it in order to prolong the insulin action. It is a slower acting insulin, again, slower compared to our rapid or our regular insulins. Um, it's going to be suitable though because it's slower acting for our longer term glycemic control. So again, that more basal control that we're looking for, not our bolus postprandial control. It's going to try and help maintain our glucose levels at that euglycemic or steady level in between our meals, as well as overnight, to cover those needs when we have those periods when we're not eating or we're sleeping. It's most commonly used in our pre-mixed formulations, which we'll see on another slide here, and we'll combine it with either that regular insulin or some of our rapid acting insulins. And it's an intermediate, so it's not a once a day thing. Its peaks tend to be about 2 to 14 hours or so. 5 to 6 hours is really kind of the middle of the peak zone. So because of that, we do have to inject it about 2 to 3 times a day in order to get our consistent insulin coverage throughout the day. It is not used for meal times, so this is not a postprandial bolus insulin. Again, this is more of a basal long-term control insulin, but because it's intermediate, we do have to inject it sub-Q 2 to 3 times a day. On to our long duration insulins, we've got our insulin glargine and our insulin detamir. When you see the U100, that means that it has 100 units in like a pre-mixed syringe. So that's what that means, is the U100 is 100 units. I see a lot of, like, if you look at review videos and that sort of thing, some people like to call these like your grumpy old dudes of insulin. And that's partly because they don't have a peak. So a lot of our other medications we talked about have a peak within some sort of hours time frame afterwards, and then they slowly taper back down. If you look at this picture on the side, you see they don't have a peak. You give it and it remains steady, and then it just has that taper off at the end right before you give the second inject or the next injection, usually once a day, because it is a longer acting medication. It is usually a once a day prolonged use. They also don't mix well. Like a lot of old dudes, they don't mix well with others. So our NPH mixes well. And that's what we use for our pre-mixed combos. These guys don't mix well. They're usually used by themselves in a separate syringe. And again, there are long acting. They last about 24 hours. So you're just giving it once a day typically. And they give that prolonged basal control in order to try and maintain steady blood glucose levels throughout the day and the night. And then you have to do the rapid acting or short actings whenever you have a meal to just control those spikes that you would get after a meal. These are given sub-Q. And then, again, I like little ways to remember things. So insulin glargine, it is a long duration. It's a large acting duration medication. And then insulin detamir lasts a year. Detamir lasts a year, so it's a long duration. Glargine is a large duration insulin medication. Okay, and our last one we're going to talk about is our ultra long duration. So again, we've got our glargine, our large duration. This is U300, and then our insulin deglutic. So our insulin deglutic is also one of our slowest acting and longest duration insulins. So we've got the long acting, and then these are the ultra long acting. And that's because they can last sometimes up to 42 hours. So it might be once daily or even once every other day injections, depending on how good of a control your patients are getting through this. Because again, they're long duration, this is not something you're using for meal coverage. This is something you're using for just extended glycemic control to ensure that you have stable insulin levels, stable glucose levels throughout the day, in between meals, at night when you're sleeping. This is going to keep you at hopefully at that euglycemic throughout the day. It is, again, usually a once daily injection. It is given sub-Q. And then again, if you look at that picture on the side, there is no peak for this. So our rapid acting, our regular insulin, short acting, our intermediates, those have peaks. So those are a little bit more considered for plates, peaks with plates, meaning peaks go with food control, so glucose food prandial control. These ones that don't have peaks are long duration, are ultra long duration, no peaks, no plates, meaning they aren't food control medications. They are long daily basal insulin, just keeping your daily levels at a euglycemic, hopefully, level. And then you do have to give something short acting for your postprandial control to make sure you don't get any spikes. This is just putting all of those medications into duration and peaks together. You can see how they have a quick peak with your rapid acting, but it only lasts for about 4 hours, with that peak being about 30 minutes to 60 minutes after you give it. So that's why you need to give it about 15 minutes before or within 30 minutes of eating to stop that blood sugar spike. Your short-acting regular insulin lasts a little bit longer. Its peak is probably closer to 2 hours, so it's not as tightly controlled, but it is another one that we give for our postprandial control or our bolus control. Intermediate acting, you'll give about once or twice a day, and that's going to be for your mostly basal control. And our intermediate NPH is what we're using in any of our pre-mixed mixtures. And then our long-acting ones are our grumpy old dudes that are antisocial and they don't mix well, so they don't go into our pre-mixed mixtures that we'll talk about here in a little bit, and they don't have a peak. So those are for our basal control. No peaks, no plates. So it's not for food, okay? This is looking at a few of our options for our pre-mixed combinations that again are going to have NPH as our basal preparation, our long-acting preparation, even though NPH is our intermediate acting. And then it's mixed with some sort of rapid or short-acting insulin. And that comes pre-mixed in its own pen. And this is going to be a twice daily medication. So it is very useful in terms of you only have to worry about giving it twice daily, but it's not something we'll typically give right off the bat. So like right when someone is diagnosed with diabetes, especially type 1 diabetes, we want to make sure we're getting strict control. So these pre-mixed options are not great for right off the bat treatment. Once we get them a bit more under control, we can play around with these premix to make sure that they're giving adequate daily control, but they're not right at diagnosis. When it says twice daily, 30 minutes before meals, that's not saying both. That is saying 30 minutes before usually breakfast and dinner, you will give this injection. So just twice a day, and it already has your basal and your bolus pre-mixed together. So you're not having to do a basal injection and then separate bolus injections with every meal. There are some machines now that are implanted as insulin pumps, primarily utilized in our type 1 diabetics, and it's going to help provide more flexible and effective methods for delivering our insulin. The studies have shown it has very similar efficacy in controlling our blood glucose if you compare it to someone that is doing like a separate basal bolus injection throughout the day. And it's going to allow for more precise delivery, which can actually hopefully improve our glycemic control in our patients. They're usually using our rapid acting insulins like our Lispro and our Aspart instead of our regular insulin. And it's going to help support more immediate glucose control, especially around those meal times, that postprandial control that we're looking for to stop that postprandial spike. The insulin delivery through the pump is typically still, like we talked about before, a 50-50, a 50% basal long-term control, 50% bolus. Again, our basal maintains levels between meals and overnight. Our bolus is given at meal times to cover that carbohydrate intake and stop those postprandial glucose spikes. If a patient needs to, based on how much they were eating or how much activity they were doing, they can adjust the doses of especially those bolus doses. And they can do that by using a blood glucose monitor throughout the day to see what their sugars are running, and they can adjust the doses if they need to on the machine in order to make sure they're still getting adequate control and not getting hypoglycemic. So if someone wants to consider going to a pump from doing daily injections multiple times a day, if they're previously controlled, it may even reduce the total daily dose they need by 20%. If they were uncontrolled before trying to switch to the pump, it's probably going to be very similar. But if it was controlled, it might actually decrease the amount of medication that they need, which is great. When we first introduced our insulins, I talked about how the big side effect of them is hypoglycemia, so dropping our blood sugar levels too low. And it is a pretty significant complication for our diabetic management. If they drop too low, it can be severe enough that it might even lead to like needing emergency intervention. We are going to classify those blood sugar levels based on the glucose reading itself and maybe how they are reacting as well. So level 1 is going to be if we have a blood glucose range less than 70, but it's greater than 54. Someone with this kind of level, they might experience mild symptoms like our sweating, shaking, hunger. uh, Intermediate intervention with like a fast acting carbohydrate is often sufficient enough to restore the levels for these people. We'll talk about that in a little bit too. Our level 2, our blood glucose is less than 54. Symptoms start becoming a bit more pronounced. They might get confused, irritable, or or not dizzy. Um, Urgent treatment is really necessary at this point to prevent progressing to level 3, our severe hypoglycemia. This is where someone is having altered mental status or they have a physical thing going on with them that is an emergency and needs assistance. They might become unresponsive, disoriented, they can't self-treat, they really need immediate medical intervention. And it's often going to require a glucagon um, administration, whether that be IV or IM. And we'll talk a little bit about that in a slide or two here as well. So level 1, if you can ask them, you can talk to them, you can typically give them some sort of oral carbohydrate. Level 3, if they're sleepy, unconscious, then you're probably going to have to stab them with something glucagon, whether it be sub-Q, IM, IV, to get them immediate sugar. So if they're awake, you can ask them to eat something. If they're sleepy, you gotta stab them with a needle to get them their sugar they need. What's causing our hypoglycemia in these patients? Because a lot of patients, they're on a pretty steady dose regularly and it's controlling their sugars fine and they're not experiencing hypoglycemia. What then caused them to suddenly get hypoglycemic from their normal dose? And there's a couple different things. The insulin levels are greater than the insulin needs, is our overarching concept. Any of these things below this um, are going to mean that excessive administration of insulin was given compared to what the body's requirements needed. So one thing is too much insulin was used. Overdosing on insulin, whether that was intentional or accidental. So you gave more than your normal dose is what this is meaning. We gave too much insulin and it rapidly lowered our blood sugar levels. Or maybe you had too little food intake. You skipped a meal, you didn't eat enough carbohydrates. There's some sort of mismatch going on between the amount of glucose available from what you ate and the amount of insulin you've given. Vomiting and diarrhea. GI disturbances are going to lead to, again, reduced food intake or reduced food absorption, which is going to increase that risk of low sugar, especially if you're giving insulin on top of it. The insulin's going to drop the sugar even further. Excessive alcohol consumption. Alcohol is going to inhibit gluconeogenesis in the liver, and that's going to lead to decreased blood glucose levels overall, especially if someone, again, is drinking excessive amounts of alcohol on an empty stomach. It's going to lead to an even worse situation. If someone had unusually intense exercise, so they're not used to exercising and now they've gone and exercised. Or maybe I've seen this in someone with like a soccer tournament. They were used to uh, practicing maybe an hour or two, and now they're at an all weekend long tournament from 8 to 5 both days, and they're trying to take their normal insulin levels. Strenuous activity can increase how much glucose is used by the muscles because the muscles need more energy given from the glucose. So that's going to lower your blood sugar levels. And then if you're using your normal amounts of insulin, it can drop you too far. And then childbirth. Um, Childbirth is such a stressful time on the body, and your metabolic demands during childbirth and immediately after are just risen so much. And this can really affect insulin sensitivity and how much glucose you're using, and it can lead to dropped levels or hypoglycemia. Okay, looking further into our hypoglycemia. So again, it's a critical complication of our insulin therapy, and it really does necessitate or need rapid intervention. If it is left untreated, it can lead to severe consequences, especially the more severe it is, it can lead to irreversible brain damage or even death. So looking at our treatment, I kind of went over this on the other slide here, but for a conscious patient, someone who is awake and able to swallow, the immediate treatment often involves a fast-acting oral sugar of some kind. So fruit juice, like a small 4-ounce glass of fruit juice, soda, regular, not diet soda. I had someone that tried to bring like a Coke Zero to someone in a hypoglycemic state. That's not going to help. There's no sugar in it. So a regular soda, candy, chewing a few pieces of hard candy. We'll see on the next slide too, kind of the rule of 15s that I'll talk about. So again, if they're awake, they're conscious, you can ask them, awake, ask to take some sort of sugar. Cool, sweaty, clammy, give them candy. Those are those like mild symptoms of your hypoglycemia. Now, if someone is unconscious, they have impaired swallowing, severe hypoglycemia, so again, that less than 54, altered mental status. If they're sleepy, you gotta stab them with something like a glucagon or IV glucose. So sleepy, stab them with glucagon. Awake, ask them to eat something.
So you've got your IV glucose or dextrose, that's going to give them like a rapid restore of their blood sugar levels, or you've got this injectable glucagon kit that you can see on the bottom here, and it's always a good idea for your diabetics to have that available with them somewhere. So we've got our rule of 15, and our rule of 15 is really just talking about, again, those patients that are awake, they're conscious, they've got mild symptoms. You're going to want them to take 15 grams of a carbohydrate. And these are all just examples of what that means, whether it's glucose tablets, some hard chewable candy, 4 ounces or half a cup of fruit juice, or again, regular soda, glucose gel, maybe a cup of skim milk. If you check your blood glucose and you are, again, between that 74 to 54 with mild symptoms, treat with asking, because they're awake, 15 grams of glucose. Wait about 15 minutes after that and check your blood glucose again. If you're still low, take another 15 grams. And if you're, then you wait another 15 minutes and check your blood glucose. And then if their glucose is normal, eat a meal or a snack to make sure you're staying normal. Once you get back to normal, eat a meal or a snack to stay normal.
Part of our patient education on our hypoglycemia is to make sure that you let your patients know what those symptoms of hypoglycemia look like, what sort of things they might be experiencing so they can recognize it early and treat it early before it gets to a more severe stage. So, with rapid hypoglycemia, they might be alert and they're starting to get a little tachycardic. They're feeling those palpitations, those flutters in their chest. They might getting sweaty, clammy, nervous, and those should be signs that something's not quite right. Let me check my blood sugar. Gradually, that might expand into more severe warning signs, including headaches, confusion. They might start getting fatigued and drowsy. And if you're not treating it by that point, it can start leading to more severe things like convulsions, coma, or even death. So, to avoid this, let them know what those warning signs are so they can start checking their blood sugar if they get those warning signs, and then instruct them to always have some sort of oral carbohydrate available, whether it be they have some hard candies readily available in their bag, glucose tablet, something like that available in case they do get low blood sugar. Another safety measure that they can do is wear a medical alert bracelet like I have pictured here. That's going to indicate their condition and help others recognize that they're hypoglycemic. You don't want someone to be passed out and someone thinks, oh, I need to give them Narcan because they passed out on like a narcotic or something else going on. Anytime you have someone with impaired consciousness, it's a good idea to get a glucose, or especially if they have something like this, then you know, oh, they're probably hypoglycemic with because they're a diabetic and I see their bracelet. Let me check that real quick and give them glucagon or give them IV dextrose or glucose. Many of these we have already talked about, but anytime you have a diabetic, you want to make sure that you are instructing them about medications that might make their diabetes worse, whether that means increasing their sugars, being hyperglycemic, or decreasing their sugars and being hypoglycemic, or as we talked about with our beta blockers, masking signs of the hypoglycemia. They don't necessarily interfere with the sugar per se, though some studies are starting to say they might actually cause some hyperglycemia. But beta blockers, since they block the sympathetic nervous system, they're going to mask those symptoms like the tachycardia, the rapid heartbeat, and that's not going to let your patient know those early warning signs of hypoglycemia.
Hypoglycemic agents, these are different things that can actually enhance insulin's glucose lowering effects, which is going to increase your risk of hypoglycemia. So insulin itself is lowering it. And then we've got some of our other diabetic medications like our sulfonylureas, our glinides that may lower it, as well as someone, like we said, is drinking excessive amount of alcohol. That can impair their glucose production as well. Then we have our agents that can actually counteract insulin's effects. So it's going to raise your blood sugar levels. We talked about this briefly last quarter as well with like your thiazide diuretics, your loop diuretics. They can actually raise your blood sugars. So you need to be careful with your patients with those. Glucocorticoids also can raise your blood sugars. So anytime you're giving even just a one-time shot of a glucocorticoid, you need to ask if they're a diabetic and tell them this may affect your blood sugars and may raise them. So you might have to use extra medication if you're an insulin-dependent diabetic. So, for the patient to be able to make sure that these medications are working well and they're doing what they're supposed to do, they're going to have to monitor their blood glucose levels somehow. One way to do it, which may be the easier, cheaper way, not that any of these are necessarily a cheap way to test these things, is your finger stick blood glucose monitoring. And I believe you guys are going to get a chance to do these once we do get back in person and I get to see your lovely faces again in Cam Lab. So what this requires is you have this little lancing device with this kind of tiny little blade needle that will prick the finger to draw a little bit of blood. That blood's then applied to a test strip, and you then take that test strip and insert it into a meter. Some brands are like AccuCheck or your One Touch, and that gives you a really quick reading on what your blood glucose is. For this, though, you have to do it multiple times a day. Typically, you'll do it before meals, after meals, and at bedtime to just check and make sure your sugars are looking okay and you don't have to do any sort of counterbalancing with bolus insulins. These are going to provide immediate blood glucose levels, and again, they're going to help adjust your insulin doses or meals kind of in real time. And then you've got these really cool devices, your continuous glucose monitoring systems. These are sensors that are placed under the skin. A lot of times you'll see them like on the back of someone's arm, like kind of like the tricep area. And what they do is they measure the glucose levels in your interstitial fluid, not necessarily directly from blood. It's in the interstitial fluid. Devices, the brands you might hear like Dexcom or your Freestyle Libre, and they're giving you continuous readings throughout the day. And they transmit this data to some sort of either reader device like you see here, or even a smartphone app. And it allows for dynamic tracking of your glucose levels and trends throughout the entire day. It may even provide you like a notification or alert or beep at you if you get high or low blood sugar levels. And this is gonna reduce the amount of finger sticking you have to do and really kind of give you really cool by the minute insights for better glucose management. Looking at our treatment specifically for our type 1 diabetics, it's insulin. Insulin, insulin, insulin. Insulin is our cornerstone. We're not using any of those oral agents that we talked about. We're not using really those injectables. There's that one injectable, our amylin medication that you could use, but it's more of an adjunct. If you see type 1 diabetes, insulin is your treatment for it. You have a few different ways you can go about it. You can do multiple daily injections with a prandial or your mealtime insulin, also called your bolus insulin, and then that's going to be combined with your basal insulin, which is administered separately, and that's going to be like your long-term control. Rapid acting insulins. So your rapid acting are your Lispro, your Aspart, your glulicine.
those are going to be preferred for your prandial doses, so your mealtime doses, due to a lower risk of hypoglycemia. So they're not going to lower the blood sugar as much. They're just trying to prevent that spike after your meal. Prandial insulin is going to be adjusted based on your carbohydrate intake, your pre-meal glucose, and then the amount of physical activity that you might anticipate doing for the day. So this might be something that's slightly different throughout the day depending on your patient needs. There's another option of that continuous insulin infusion pump. It's going to use rapid acting insulin for basal and bolus doses, and it's great for flexibility in insulin delivery, and it's going to reduce those risks of hypoglycemia. But overall, the important point to get as far as your insulin dosing is your total daily insulin dose is typically between zero point 0.4 to 1 unit of per kilogram per day. Most of the time, you're going to start at 0.5 units, so half a unit of insulin per kilogram per day for metabolically stable patients. Insulin is going to be divided then into 50-50. Half of your insulin, 50% of your insulin is going to be your basal insulin, your long-acting insulin for around-the-clock control. So that's in between your meals, at night when you're sleeping. And then half of it is going to be divided across your meals. So you're not going to give just half of it one time for basal, half of it one time for prandial. You're going to divide that basal depending on what you're giving in either a one-time dose or a two-time dose for the day, whether it's like your long-acting glargine versus your intermediate NPH. And then you're going to have your prandial insulin divided across 3 meals. So you'll divide that by 3, and we'll look at that math on a few slides here. And you'll have half of your insulin divided by 3 with a third of it given usually between 15 minutes or so before each meal. There are going to be certain times where you might need higher doses, and that's typically more stressful times like pregnancy, puberty, or if someone has a medical illness or is in, again, a very stressful time. As I talked about previously, we do have some of these twice daily pre-mixed dosing pens, and they're going to include both a prandial, so your mealtime, and your bolus insulin. But remember, the only one that can mix is your NPH. You can't mix those other long actings. Remember, they're grumpy old men. They don't socialize well. They don't mix well. So only your NPH can be mixed. So again, prandial for your mealtime with your NPH basal insulin for your ongoing long-time control. And this is going to be dosed twice daily, 2 injections per day, which does make it really simple and more convenient for patients. But you have to think you're only giving it breakfast and lunch, so you're not getting as good of lunchtime coverage for your patients. And then there's no room for flexibility, so no individual adjustments of the insulin doses based on if they're having a more heavy or more light carbohydrate meal, or if they're having a heavy activity exercise day. There's no room for coverage for that because they just have that one premix thing. Looking again at the different types of insulin usage that we can do when you're managing your diabetes, the basal bolus insulin strategy is going to be used pretty commonly to really mimic the body's natural insulin patterns. We're trying to get people to do exactly what their body is normally doing. And this is going to separate the insulin into 2 types of actions again. Your basal, which is continuous, low-level insulin coverage to control those sugars in between your meals and overnight, versus your bolus or your prandial insulin, which is going to give that rapid acting coverage after meals to correct any hyperglycemic spikes. This is going to be a bit more flexible and individualized for your insulin management, and it's going to allow a little bit better control of your fasting plasma glucose or your postprandial glucose levels. To do this dosing, which you might have to do, hint, hint, wink, wink, wave my arms, cartwheel, whatever I normally would do in class, is to start your basal insulin initiating at a low dose. So either 10 units daily or 0.1 to 0.2 units per kilogram per day. And you're going to titrate this based on the patient's fasting plasma glucose readings. This gradual adjustment will help prevent hypoglycemia while trying to reach those target blood sugar levels that we want. However, you must make sure you're taking care to avoid basalization. This is where the basal insulin dose exceeds 0.5 units per kilogram, and this is going to lead to hypoglycemic risks, glucose imbalances, and there is a pretty high variability between all your patients. Uh, when you're trying to titrate this, so you're starting at that 0.1 to 2, you're looking for that fasting plasma glucose target. And then if it's not quite where you want it to be, you'll increase your 2 units every 3 days to try and reach that. If they're having hypoglycemia though, so it's doing too much and you don't have like a clear cause, like they had a tournament, they weren't eating as well, they had a GI thing going on. If it's just hypoglycemia, possibly because of overbasalization, then you're going to lower your dose about 10 to 20%. However many units you have, lower it by 10 to 20%. So that last slide, we were talking about more of our basal, our long-term control, our fasting plasma glucoses. This, we're going to be talking more about our bolus, our prandial, our after meal insulin to control our post-meal blood sugar spikes. To start with these, you're typically going to start with 4 units or 10% of whatever that basal insulin dose was. And you're going to do these about 15 minutes before your meals. If your hemoglobin A1C is less than 8%, consider reducing your basal insulin by about 4 units a day or 10% of the basal dose when you're adding these bolus insulins on. So not everyone, like a type 2 diabetic, is going to start with basal bolus. They might just start with basal. If you're then adding on a bolus, that's where this comes into play. Your type 2 diabetics, if their A1C is less than 8, consider when you're adding these bolus insulins on, reducing that basal insulin by 4 units or 10%. When you're trying to look at these to see, is this accurate? Is this where I want to be? Increase the bolus dose by about 1 to 2 units or 10 to 15% twice a week if your levels are still hyperglycemic. If you're getting hypoglycemic, meaning you're doing a bit too much, lower those units by about 10 to 20%. You want to start by targeting the largest meal of the day because this typically is going to be where you're going to get that highest post-meal, postprandial spike and progress to dosing before 2 to 3 meals daily if needed. Again, this is going to be for those type 2 diabetics. Those type 2 diabetics will see later that you might add that basal long-term insulin, and this is talking about how you add that bolus insulin onto those patients. Being able to adjust your insulin doses based on out-of-range blood glucose readings is really crucial for effective diabetes management. And this kind of gives you a breakdown of determining which insulin you need to adjust based on your blood glucose readings that you're looking at. They love to ask questions about out-of-range fasting blood glucoses and what you're going to be adjusting. So if you have a fasting blood glucose that's reading high, you're going to adjust that basal insulin. Those basal insulins, remember, are your long-acting or intermediate acting. So like your glargine, your degludec, your NPH, your intermediate acting. And the rationale behind this is that high fasting glucose levels typically are going to indicate insufficient, not enough basal insulin. So you're going to adjust those basal doses to help lower fasting glucose levels. And again, opposite of that. If you're waking up hypoglycemic, then you're doing too much with those basal insulins. And then as you look through this chart here, you can kind of see what we mean on like your pre-meal blood glucose high readings. It might mean that your prandial or your bolus insulin, so like that pre-breakfast rapid insulin or your short-acting insulin, that might be doing too much or too little. So if you have like a high pre-meal reading, it suggests the need for more insulin of that bolus insulin to manage the carbohydrate intake at that meal. So if you're getting it every day, you're getting a high pre-breakfast or post-breakfast reading, you're going to want to adjust the dose before that meal in order to lower that glucose level a little bit. If you're having any confusion with what these mean, certainly reach out to me. Occasionally, your patient is going to need to do some sort of adjustment or correction to their insulin dosing based on their meals. So what you're going to do with this is either you're going to have the insulin to carbohydrate ratio, which is up at the top there, versus your correction factor. Both methods are going to help individuals with diabetes kind of manage their blood glucose levels more effectively, tailoring it based on just that dietary intake from that day or how their blood glucose is acting that day. We're going to have separate sides on all of these and how to do the math a little bit later here. But for our insulin to carbohydrate ratio, we're looking at how many carbs are being consumed to tell us how much insulin, bolus insulin, rapid acting insulin do we need to give to cover that amount of carbohydrates. And then we've got our correction factor. It's also known as like our insulin sensitivity factor, and it's going to tell us how much 1 unit of insulin will lower blood glucose levels. This is going to help us kind of address our blood glucose levels that may not be controlled by that basal or prandial insulin alone. So we took our normal dose, we get our post-meal glucose level, and it's still running high. We can use this correction factor to figure out how much more do I need to drop this based off of what my glucose currently is. Starting off with our insulin to carbohydrate ratio, this is one of our adjustment factors that we just talked about, and it's going to be particularly good for those kind of intensive insulin regimens for people that really kind of fluctuate all over their place day to day. And this is going to allow them to calculate the necessary insulin dose based on how much they're eating, how many carbs they're intaking for every single meal. It does require pretty specific skills, and you're going to have patients that aren't going to be able to do this because they're going to need to be able to do pretty intensive math. They're going to have to be able to read and estimate how many carbohydrates are in each meal they have by reading the labels, using carb counting books, employing apps that track the carb intake. And they're going to have to maintain like a food log to be able to monitor this carbohydrate intake and the amount of insulin that they're dosing. So it can be pretty intensive for your patients. You have the rule of 500. It is fairly straightforward, but again, it's not going to be for every patient. And this is going to establish the carbohydrate ratio on the total daily dose of insulin. So the calculation is the insulin carbohydrate ratio is going to equal 500, or again, rule of 500, divided by the total daily dose of insulin. If the patient's total daily dose of insulin is 50 units, you're going to have 500 divided by 50 equals 10. This results in a carbohydrate ratio of 1 to 10, meaning that the patient needs 1 unit of insulin for every 10 grams of carbohydrates that they consume. The goal of this factor that we're using, this adjustment factor, is to correctly calculate how much they need to adjust it for their blood glucose levels to return to that target range about 2 hours after the meal. The correction factor is another critical tool for your diabetics, and it's going to be really useful for people who might have a higher spike after their meals, where their normal postprandial dose or preprandial dose didn't cover it. And with this, we're looking at the rule of 1800. The last one was rule of 500. This is 1800. And this is specifically applying to our rapid acting insulins. And it's going to help us kind of determine how much 1 unit of insulin, again, will lower blood glucose level. So our calculation for this, we're looking at our formula for determining our correction factor. Our correction factor is going to equal 1800, rule of 1800, divided by the total daily dose of insulin. So if we look at this example, to determine our total daily dose, let's say our total daily dose is 60 units, apply the rule of 1800. 1800 divided by our total daily dose is 30. That means 1 unit of rapid acting insulin is going to lower the patient's blood glucose by 30. So we're going to use this. We can either do it before meals, we can calculate it after meals, and before meals, the patient checks their blood glucose level. If their reading's like 180 and their target is 120, the patient needs to calculate how much insulin is required to correct this elevation. So we'll look at this in a different slide here too. So we had to figure out what our correction dose, correction factor was on the last slide. And now we have to figure out what our dose is for that. So we've got this formula now. The correction dose is going to equal our current blood glucose versus what our target is, and then divide it by that correction factor that we just figured out. So determine the current and target blood glucose levels. They will get their current finger stick measure or glucometer measure, figure out what their target is, and then they will divide that by whatever that correction factor that we just figured out was. So for example, we'll look at another example on a different page. But again, if our current blood glucose is 180, our target is 120, we figured out that our correction factor was 30. That is going to be the 180 minus 120 divided by 30, which gives us a dose of 2 units in order to correct our blood sugar to our target goal of 120. This is just a brief overview on what we're looking at as far as initial therapy for our type 2 diabetics. Initially, it does somewhat depend on what their A1C level is. So if their A1C is like 7, we're going to really look at like lifestyle first. If it gets to 7.5, we're generally going to start a medication. Metformin is typically our starting point. But as the first and the third little boxes here say, if they've got cardiovascular disease, kidney disease, heart failure, you might want to look into your SGLT2s or your GLP-1s. And then you also want to look at if their A1C is climbing to over 10%, you may need to start them on an insulin, like at least a basal insulin right away. If it's over 8.5%, you may consider starting them on dual therapy right away, so metformin plus a different medication. Okay, here's our money slide. This is our type 2 diabetes kind of stepwise approach on how you're going to manage them. First, diagnosis. Once they are diagnosed, it does somewhat depend again on what their A1C is, but your initial approach is going to be lifestyle changes. Emphasis on your dietary modifications, increasing that physical activity, trying to achieve some weight loss. Your medication that is first line is your metformin. Metformin is your first line pharmacotherapy. Metformin is your biguanide. Remember, met for men, big guy, met for men. Just to review some of those slides we talked about last week. And remember, your metformin is primarily working by decreasing hepatic liver glucose production, increases insulin sensitivity, and enhances glucose uptake in those peripheral tissues. It is pretty weight neutral, may even have a little bit of weight loss. There's not much risk for hypoglycemia, and it may even have a little bit of cardiovascular benefits. Step 2. When do we get to step 2? If your glycemic control is not achieved with lifestyle changes and metformin, or like the last slide said, if you're having like an A1C starting off at 8.59%, consider adding a second drug, like your TZDs. These are going to increase insulin sensitivity in those fat and muscle tissues. These are your glitazones. Remember, your big thing about your TZDs is they can cause heart failure. They can cause heart issues. So you want to make sure that is a red flag there. Your DPP4 inhibitors, these are your incretin mimetics. They're enhancing incretin levels, which is going to increase insulin secretion, decrease glucagon levels. Those are your gliptins, sitagliptin, saxagliptin. You could add your SGLT2 inhibitors, your flozins, that also have those side effects of your UTIs, your fungal infections. These are going to promote glucose excretion via the kidneys. They're promoting excretion during the kidneys. They're promoting urine with glucose in the kidneys. They're making the urine flozin, which is going to cause your UTIs. And then you could also consider adding like a GLP-1 receptor agonist, like your liraglutide, your semaglutide, those glutides. These are, again, incretin mimetics, and they also are going to stimulate insulin secretion and inhibit glucagon release. You could consider adding insulin if blood glucose levels remain uncontrolled, or if like they're starting off with a A1C over 10.5%, then consider just starting them right off with a combo of metformin, maybe one of these other drugs, plus a basal insulin. Step 3, patients who still do not achieve their glycemic target with dual therapy, the 2 drugs, then you might need a 3-drug combo. So this is definitely going to include adding that basal insulin with your metformin, and then one of the previously talked about drugs in step 2 in order to really attack that glucose level. And then step 4 is some sort of injectable combo. So it's going to be typically like a GLP-1 receptor agonist with your insulin. This is really going to improve weight loss, glycemic control, and minimize those risks of hypoglycemia because the GLP-1s don't really cause too much hypoglycemia. So for example, you could use, again, a basal insulin, so like your glargine, large duration, with a GLP-1 receptor agonist, your glutides, like a liraglutide or semaglutide. So don't listen to this explanation of my answer until you kind of read through our little vignette here and look at your answer choices. I'm going to sing a little Jeopardy song here and then give you what I am looking for in this little case so you can wait Do 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 do. Okay, hopefully you've paused it, you've looked through it, you've thought through it. And now we're looking at our patient and what is going to be our most appropriate first line. It can go a little two ways here, but typically metformin is our standard first line treatment for type 2 diabetes because it's effective in lowering our blood glucose levels, it's extremely safe, and it does also have some potential cardiovascular benefits, especially with this guy having a history of myocardial infarction. So it's a great choice. I would definitely probably pick metformin. You could, I know in some of our slides said, consider like an Ozempic, a semaglutide. And while it is effective for weight loss and our cardiovascular benefits, it's still not typically first line because it's an injection versus metformin being oral, and it can be quite expensive, but it is an option. Our sulfonylurea glimepiride can typically cause hypoglycemia as well as weight gain, so it's going to be less favorable, especially with this history of MI. And then we've got our sitagliptin or Januvia, and it is a DPP-4 inhibitor. It's got a pretty favorable safety profile, but it's not as effective as metformin in terms of lowering our glucose, and it's not typically one of our first line choices. And wait till you read our little case here. Pause this little audio. Do 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 do. Ignore my terrible singing voice, giving you a chance to find the pause button here until I go over this one. Okay, our guy's coming back in. Type 2 diabetes. We had placed him on metformin, slowly titrated him up because we know we got to titrate to avoid those nausea, vomiting, diarrhea, GI side effects to his max effective dose of 1,000 milligrams twice a day. He still has that MI 2 years ago, and he's had improvement, hooray, in his glycemic control. So what do we want to do now for him? So really, I would probably say no changes at this time. His A1C is improved from 8.2 to 7.5. Is it at our goal? Not quite, but it's only been 3 months. So it's improving, so let's give it a little bit more time probably. His GFR is slightly impaired, which might make it where we don't want to use like a GLP-1 like semaglutide, or cautious dosing with like our glimepiride. So we probably don't want to do that. Um, his A1C is still above that target range. So I would consider, because it is improving, continuing our current treatment and considering making sure that he really is doing lifestyle modifications. If the next visit it's still elevated, then we might consider adding something else on. Giving you a chance to pause the audio, because some people the audio is going to start right away. Okay, hopefully you have found your pause button. Let's go over this guy a little bit. So considering his concerns for hypoglycemia, as well as his desire for weight loss, he's already on metformin. What are we going to recommend? My choice would probably be our Ozempic, our semaglutide injection once a week. And why am I picking this? Our hypoglycemia risk. Ozempic and our GLP-1s have that lower risk of hypoglycemia when you compare them to our like glimepiride or sulfonylurea, and they might actually aid in weight loss, while our sulfonylurea might cause a little weight gain. Ozempic, Victoza, or liraglutide or semaglutide can both cause weight loss, but semaglutide tends to be a bit more effective. We talked about that in our course last quarter, that semaglutide tends to be more effective than the liraglutide. He's already on metformin, so this is where we kind of went through that stepwise approach. If he's still above target and he's been on it, then we want to go to that dual therapy. So adding Ozempic with the metformin can help enhance his glycemic control as well as address his weight loss concerns. Again, our glimepiride or sulfonylurea can actually increase our risk of hypoglycemia, especially like this guy's a long distance truck driver. His eating patterns might be a little bit more erratic, so we don't want to increase that risk of hypoglycemia. Liraglutide, very similar benefits to our semaglutide, but it's actually also a daily dosing instead of our semaglutide, which is a weekly dosing. And then our glargine is our basal long-acting insulin. It's not ideal at this point, especially with his concerns, again, with hypoglycemia, and it's not going to cause weight loss. Sometimes the insulins could actually cause weight gain. So that's why I went with our semaglutide once a week. Okay, now we've got this 66-year-old male, uncontrolled diabetes. He's losing weight. He's having to go to the restroom more frequently. He's always thirsty. Those are those hyperglycemic symptoms, polydipsia, polyuria. And then we look at his labs, 13%. Oh my goodness, that is so high, even though he's on metformin 500 milligrams. So what's our most appropriate therapy for this guy today? I would probably go to adding on that basal insulin, that Lantus glargine 12 units sub-Q once daily. And why am I going to do that? Um, if you look at that stepwise approach or on one of those charts, I said if their A1C is over like 10.5%, really consider adding on a basal insulin. He's at 13%. He's having those hyperglycemic symptoms. Adding on that basal insulin right now is really appropriate for such a high A1C. Uh, Ozempic is going to promote weight loss, and he's already losing weight, and it's not necessarily our first line for uncontrolled diabetes. He's got a GFR of 55, which shows some impairment. So we really want to use caution with like our GLP-1, again, Ozempic, semaglutide, because it might have some dose adjustments or be contraindicated in this guy. Um, and Lantus is pretty much a pretty good suitable choice to help manage his diabetes without adding more risks for this guy. Okay, so this guy comes back into the clinic, 3-month follow-up. We had him on that long-acting glargine insulin, and here are his blood glucose readings. What do we want to do with this guy today? Looking at his current blood glucose, fasting blood glucose levels, they're still elevated with that range of like 130 to 172. And then his postprandial blood glucose levels are still significantly high, peaking at like 260. Those are nowhere near our target that we're looking for. This is telling us that that basal insulin alone, the glargine Lantus, is not sufficiently controlling his blood sugars, especially after our meals. So my choice that I would go with looking at this is adding now a bolus insulin, a rapid acting thing like Humalog or Lispro. Remember, it's a pro, it's less time, less pro, so it acts fast. It's a rapid insulin. And this is going to help to better manage his post-meal glucose spikes. Doing it about 15 minutes before his meals should really help give him some prandial coverage and hopefully improve the glucose readings throughout the entire day.